Well, good evening. I want to welcome everybody who's attending live to this week's unknown session. We're going to be discussing, at the request of a couple of people who regularly attend these, a few classic spongiotic and psoriasiform dermatitis. I think we've touched on some of these in prior videos, but they haven't really been discussed together. And certainly this isn't going to be entirely inclusive, but I'm hoping that a discussion of these will illustrate some principles that will be helpful in your approach to this particular group of disorders. First of all, let me go ahead and advance my slide. As always, if you have any questions, I'll be looking at the chat, but if you think about them after the fact, or if you're watching this later, you can submit them to education@sagisdx.com, or I certainly don't mind you emailing me directly at tdavis@sagisdx.com. And I think, before we get started and look at the cases, I would like to touch on a few general principles. First of all, just basics. Spongiosis, of course, is defined as intercellular edema. And what happens, of course, is tissue fluid accumulates between the keratinocytes, stretches them, and there's usually accompanying exocytosis of inflammatory cells. And if the spongiosis or edema gets severe enough, of course, you can get intraepidermal and at times even subepidermal vesiculation. And of course, the spongiotic dermatitis, or spongiotic changes in the epidermis, give rise to the clinical conditions that we call eczematous, or at times spongiotic derm. On the other hand, psoriasiform dermatitis are characterized by epidermal hyperplasia. Psoriasis is the prototype, and so the term for the entire group of disorders that tends to be applied is psoriasiform. And most of the conditions that demonstrate psoriasiform epidermal hyperplasia clinically present as our papulosquamous dermatitis. Now, obviously, there's considerable overlap in these two patterns of inflammatory skin disease. And I think that overlap is best understood in the context of considering the concept of lives of lesions. And this was a concept that was written about extensively and kind of popularized and expanded upon by doctors Ackerman, Bernie Ackerman, and Anna Ragaz. They actually had a book called Lives of Lesions, and it really kind of follows, much as the clinical picture of a given disorder evolves over time. The histologic changes also evolve over time. And I'm hoping by the end of this session that you'll really see that what begins sometimes as a spongiotic dermatitis in late stage, if untreated or as part of the natural progression, may ultimately end up as a psoriasiform dermatitis. Likewise, what in classic form is a psoriasiform dermatitis in early stages may show very little in the way of epidermal hyperplasia. And so there can be considerable overlap, and it's pretty logical to discuss spongiotic and psoriasiform dermatitis together. Also, I think it's useful to think in terms of prototypes of the pattern. I think most of you are probably already doing this. So our prototypical example, let's say, of an acute eczematous dermatitis or of a spongiotic or eczematous dermatitis in general might be something like contact dermatitis or nummular dermatitis. Our prototype of a psoriasiform dermatitis, obviously, is psoriasis. And it's a good idea when you're first starting derm path, and even as you advance, to pick out a prototype of a given inflammatory pattern and learn it really well, what it looks like early in the course of the disease, what a fully developed lesion looks like, what a late or partially treated lesion looks like, and then you'll have a benchmark against which to compare and contrast other conditions which demonstrate histologic overlap or are also in the differential of the disorder exhibiting that pattern. And then finally, clinical pathologic correlation in this group of disorders is essential. And that's especially true with spongiotic dermatitis. There's considerable histologic overlap in conditions which clinically may be distinctive. And so if we've got an acute or subacute spongiotic dermatitis, because the differential is so broad, specificity in diagnosis and generation of a clinically relevant differential really requires input from the clinician, or as a dermatopathologist, if we can review the medical record and the clinical photos, then we can really narrow our differential. So that being said, let's go ahead and get started. Our first case, case 1, this was a classic example of an acute eczematous dermatitis. And when we think about an acute eczematous dermatitis clinically, what I tend to think of is acute allergic contact dermatitis. So picture in your mind somebody with very recent onset, say, Bruce dermatitis. Generally, the clinical lesions are vesicles. Vesicles, tense vesicles, and or bully. They tend to show very little crusting or serum. There's usually not a lot of erythema, and the vesicles are intact. And we're seeing such changes here. This is a punch biopsy from the trunk. There's a superficial perivascular infiltrate. And if we move to higher power, we can see that the cornified layer is vascular weave. Of note, there's no serum or crusting in the stratum corneum. The epidermis demonstrates striking spongiosis or intercellular edema with widening of the intercellular spaces. And in areas, this has progressed to intraepidermal vesicle formation. And within the blister cavity, we can see serum, we can see inflammatory cells. There are lymphocytes here and fairly numerous scattered eosinophils. There's also striking papillary dermal edema. And within the underlying dermis, there's a perivascular infiltrate of lymphocytes. And if you looked at the sections down in the dermis, hopefully you began to see scattered eosinophils within the infiltrate. So we've got an acute spongiotic dermatitis with lymphocytes and eosinophils. And in the absence of clinical data, the differential would be fairly broad. It would include things like allergic contact dermatitis or nummular dermatitis, a spongiotic drug eruption, possibly even something like florid atopic dermatitis, although that typically doesn't demonstrate this degree of spongiosis. This patient clinically, the images I reviewed and the clinical history were consistent with allergic contact dermatitis. And so this case was signed out as acute spongiotic dermatitis consistent with allergic contact dermatitis. Moving on to slide 2. Slide 2 was an example of a subacute spongiotic dermatitis. This could be either subacute or subacute to chronic spongiotic dermatitis. Well, what do we see clinically in such lesions? Well, in subacute lesions of contact dermatitis, these are later than the case that we looked at in slide number 1. And what happens with these lesions over time? Let's go back to our patient with Bruce dermatitis. Well, the blisters, the vesicles, are going to ultimately rupture. They're going to be carried up with the keratinocytes to the surface. The serum and inflammatory cells are going to make their way up to the stratum corneum. And so clinically, the surface of the specimen is going to become crusted. The lesions are usually quite pruritic. Patients tend to scratch them. So we get associated epidermal hyperplasia. And the spongiosis or vesiculation in a subacute to chronic eczematous or spongiotic dermatitis becomes less pronounced. So we see the classic changes of spongiosis and epidermal hyperplasia or a spongiotic psoriasiform dermatitis. Of note here, there is scale crust within the stratum corneum. We have serum and parakeratosis. The epidermis is characterized by somewhat irregular epidermal hyperplasia. There is intercellular edema with extension of lymphocytes into widened intercellular spaces. There are dilated vessels in the papillary dermis. And once again, there's a perivascular infiltrate containing lymphocytes and eosinophils. The infiltrate here clearly is a little bit more robust than we saw in slide 1. And again, we have epidermal hyperplasia and scale crust within the stratum corneum. The differential in this diagnosis, in the absence of clinical history, would include subacute to chronic allergic contact dermatitis, nummular dermatitis, a drug eruption, possibly even an id reaction, atopic dermatitis. Once again, the clinical history and the accompanying images supported the diagnosis of allergic contact dermatitis. And so we have in this instance, subacute allergic contact dermatitis. Now in its most chronic form, a primary eczematous or spongiotic dermatitis is going to show just frank lichen simplex chronicus. And we see this with atopic dermatitis. Sometimes in the antecubital or popliteal fossa, you'll see nothing but lichenification. Real chronic spongiotic dermatitis frequently demonstrates irregular epidermal hyperplasia, a variably dense infiltrate, and within the cornified layer, not quite as much scale crust. One may see a little bit of serum, and the only clues that one's dealing with the spongiotic dermatitis in that case may be a little bit of intercellular edema. So the bottom line is a chronic eczematous dermatitis may indeed on biopsy just be psoriasiform. Okay, let's go ahead and move on to our next case, slide 3. And slide 3 demonstrates a change that we see a lot. This is more of a very focal or focal spongiotic dermatitis or subtle spongiotic dermatitis. In this particular punch biopsy from the trunk, we have a superficial perivascular infiltrate of lymphocytes. The epidermis is maybe a little bit mildly hyperplastic. And one can begin to detect as one moves into higher power, subtle mounds of parakeratosis within the stratum corneum. A few of these contain a little bit of serum. And when we look in the underlying epidermis, we see very subtle and focal microscopic spongiosis. There's stretching of these intercellular bridges. There is a rare lymphocyte extending into the widened intercellular spaces. And in this case, we have an infiltrate of lymphocytes and fairly numerous extravasated erythrocytes within an edematous papillary dermis. This was a biopsy of pityriasis rosea, but in the absence of good clinical data, the differential would indeed be broader. Similar, identical changes may be seen in lesions of erythema annularis centrifugum, and also in subtle expressions of other commonly encountered eczematous dermatitis, such as allergic contact dermatitis, nummular dermatitis, or spongiotic drug eruptions. So again, the top two items when we see a very focal spongiotic dermatitis like this tend to be pityriasis rosea and DAC, and possibly a spongiotic drug eruption. But once again, correlation with clinical findings is recommended. Moving on, some of the spongiotic dermatitis that we see histologically are characterized by more specific and defining histologic features. Slide number 4 was an example of seborrheic dermatitis. This is a biopsy from hair-bearing skin from specifically from the face. We've got terminal hair follicles, we've got solar elastosis, and one can see that there is quite a bit, let me get my pencil here, of spongiosis involving the epidermis and the adjacent follicular infundibular epithelium, with some extension of lymphocytes and even a few neutrophils into widened intercellular spaces. The characteristic features that we see that are defining for seborrheic dermatitis, in addition to the spongiosis, are the presence of mounds of purulent scale crust located at the lips of this follicular ostium. And this constellation of findings is very characteristic and suggestive of seborrheic dermatitis. In this case, if there was any clinical data that indicated that the presentation was somewhat atypical, one would want to do a PAS, of course, to rule out tinea faciei. Another example of a spongiotic dermatitis, which has a few more defining features, is a stasis dermatitis. And this is kind of a chronic lesion. There's actually not much in the way of spongiosis here. There is a little bit of irregular epidermal hyperplasia, a little bit of spongiosis, a little para within the stratum corneum. But what we can see is pronounced nodular angioplasia within the papillary dermis. Sometimes with stasis dermatitis, one will see lymphocytes and eosinophils and siderophages in the dermis and a little bit more microscopic spongiosis. But again, the anatomic location here helps one out. And a lot of times, you know, in the setting of stasis-related vascular change or stasis dermatitis, there may be an associated or overlying allergic contact dermatitis. Okay, we'll close out our discussion of spongiotic dermatitis with really what I consider to be more of a reaction pattern. And that will become more obvious as we discuss this case. Punch biopsy from the trunk. There is a basket weave cornified layer. And if we look at the epidermis, we can see that it is mildly acanthotic. And there is evidence of epidermal spongiosis with extension of lymphocytes and numerous eosinophils into widened intercellular spaces. There are also a few dyskeratotic cells in the epidermis. And so what we have here is spongiosis with eosinophils or eosinophilic spongiosis. And this is more or less a reaction pattern because, like most reaction patterns, there's not decided specificity with it. So we have a differential when we see spongiosis with eosinophils, as you know from reading Elston's text and most textbooks of dermatopathology, the happy differential. And it includes a variety of conditions, including immunobolus disorders such as herpes gestationis, pemphigoid pemphigus. Of course, one can see it in allergic contact dermatitis and in bite reactions, as well as in Incontinentia pigmenti and erythema toxicum neonatorum. So going back to the case in question, this was a case of Incontinentia pigmenti. A couple of clues here. One, this is very, very young skin. The sebaceous glands are small in the feet. There's no solar elastosis. There is a slight increase in the number of fibroblasts in the dermis, which is characteristic of young skin, and the adipocytes are somewhat small. Furthermore, when one sees spongiosis with the eosinophils in concert with scattered dyskeratotic cells in the epidermis, especially if it's young skin, one really needs to consider Incontinentia pigmenti, the vesicular stage, and that's indeed what this was. Now, it's very interesting. As you guys are aware, these lesions tend to become verrucous over time. And as the patient develops verrucous papules, rather than seeing spongiosis, one sees epidermal hyperplasia. And so if you biopsy one of the verrucous papules, what you see is not a spongiotic dermatitis, but a psoriasiform dermatitis Usually there's not much in the way of spongiosis with the eosinophils. One sees striking dyskeratotic cells within the hyperplastic epidermis, and sometimes those dyskeratotic cells actually calcify. So again, we have another example of a condition which starts out as a spongiotic dermatitis, but in the late stage shows psoriasiform epidermal hyperplasia. Okay, we'll go ahead and move on to a few psoriasiform dermatitis. And we'll begin with this case. This was slide number 7. And the diagnosis in this example, of course, is plaque-like psoriasis. And this is our prototype for the whole group of disorders characterized by epidermal hyperplasia. This particular specimen had, and I believe it was, this was from the distal extremity, had everything that you need to make the diagnosis of a psoriasis. Let's begin in the cornified layer. We have extensive, nearly confluent parakeratosis, and there are neutrophils within the foci of parakeratosis. There's a little more serum in this particular lesion of psoriasis, a little more scale or scale crust than one typically sees in psoriasis. In most cases, psoriasis has very dry parakeratotic mounds without much serum, the exception being intertriginous regions and alveolar surfaces. In most areas, the granular layer was thinned to absent. There are collections of neutrophils within the epidermis, some forming small little spongiform pustules. The papillary dermis contains dilated and tortuous vessels, and these closely approximate the undersurface of suprapapillary plates that are quite thin. There were a few suprabasal and mycotic figures within the epidermis, and there's a sparse superficial perivascular infiltrative lymphocytes centered around vessels of the superficial vascular plexus. So really, we have everything here that one would want to see in a lesion of plaque-like psoriasis. Slide 8 was a little tougher. Slide 8 was a lesion of guttate psoriasis. And you can see this was, guttate psoriasis usually has an explosive onset. This was a fairly recent lesion. And you can see, even though this is psoriasis, there's really not much in the way of epidermal hyperplasia. What are the features that we see that point us to the diagnosis of psoriasis? Well, again, we've got extensive confluent parakeratosis within a thickened stratum corneum, and at the summits of the parakeratotic foci, in many areas, we have collections of neutrophils. And note that there's not much serum here. We have a few neutrophils and subtle foci of spongiosis within the epidermis. And just like we saw in our case of plaque-like psoriasis, there are dilated vessels in the papillary dermis and thinning of the suprapapillary plates. This biopsy was from the lower extremity, and you can see we've got a little bit of nodular angioplasia or stasis-related change, and an infiltrate of lymphocytes and a few neutrophils. So while late lesions of psoriasis are fully developed, have epidermal hyperplasia, I find that features that are more helpful to me in recognizing psoriasis are dilated vessels, thin suprapapillary plates, and neutrophils within the cornified layer or within the epidermis. Okay, let's go ahead and move on to our next case, slide 9. Slide 9 was an example of Lichen simplex chronicus, another commonly encountered psoriasiform dermatitis. A lot of times the biopsies that we see of LSC are like this on sun damage skin, and they're submitted to rule out LSC, rule out squamous cell. Even if you didn't go to higher power, one can be suspicious for the diagnosis or suspect of Lichen simplex chronicus or prurigo nodularis. We've got the hairy palm sign. So clearly this is a biopsy from sun damaged skin. that is hair bearing. We've got a hair follicle and a sebaceous gland here. But if we look at the cornified layer, it's got a cornified layer like stratum corneum, it's got a cornified layer like a volar surface, palm or sole. And we know we don't have hairs on the palm or sole, and so we've got our hairy palm sign. So in addition to the markedly thickened cornified layer with compact orthokeratosis, we also have pronounced hypergranulosis. The epidermis is characterized by more irregular hyperplasia than we saw in psoriasis. In psoriasis, we had the nice bulbous reedy. Here, the pattern of epidermal hyperplasia is a little bit more irregular. The papillary dermis is thickened by coarse collagen and vertical streaks. And in this particular instance, as we commonly see in LSC, there's not much in the way of an inflammatory infiltrate. Usually the condition that is triggered LSC, if there was an antecedent condition, is long gone by the time the lesions are biopsied. So again, another example of a psoriasiform dermatitis. And we'll close out our discussion of psoriasiform dermatitis with slide number 10. The correct diagnosis in this case is PRP. PRP is a really tough diagnosis to make. And I found that oftentimes it's only when I see the second or third biopsy, unless the changes are 4+ like they are here, that I really think about the diagnosis of pityriasis rubra pilaris. So we got a trisected shave biopsy here from sun-damaged skin. We can see that there's hyperkeratosis and that the epidermis is hyperplastic, but it doesn't have that nice uniform hyperplasia that we saw with psoriasis. And indeed, some of the reedy here are a little bit stubby. There's a perivascular infiltrate, but we really don't have thinning of the suprapapillary plates, nor do we have the degree of vascular dilatation that we saw in psoriasis. If we look at the cornified layer, it's quite perikeratotic, and we have a little bit of that checkerboard pattern of perikeratosis, with the perikeratosis alternating horizontally and vertically within the stratum corneum. But take a look, there are no neutrophils within the stratum corneum. And again, that's very suggestive of psoriasis. And if I'm thinking PRP but begin to see neutrophils, I start backing off from PRP. In addition, in this case, we've got a nice big follicular plug here. I think it was even better seen in this top piece. So we got a follicular plug, which is another feature we look for in PRP. And then if you take a look at the top piece over at the edge, you have this is pixelating a little, I'm sorry. We've got a little focus here of suprabasilar acantholysis. And when you see acantholysis in a psoriasiform dermatitis, you want to think about the possibility of PRP, because it's been reported to occur in 10 to 15 to 20% of the cases of PRP. So this is a really nice example of PRP. Again, psoriasiform dermatitis, kind of stubby, reedy, the characteristic checkerboard pattern of perikeratosis, follicular plugging, and if you've got acantholysis, that's also very suggestive. What distinguishes this from psoriasis? Again, we don't have thinning of the suprapapillary plates, and there are no neutrophils within the stratum corneum. But again, this is a condition that really can be difficult to diagnose, frequently takes multiple biopsies, and really requires clinical pathologic correlation. So that's kind of our quick and dirty foray through Spongiotic and Psoriasiform dermatitis. Certainly not entirely inclusive, but hopefully it'll get you give you a start, and you've got some classic examples against which you compare other disorders showing these findings. And if anybody has any questions, please feel free to contact me. What was the case for case 8? Let me just run through them again. I'll just give you the diagnoses. I may have gotten them a little out of order because I added the text slide. So the first case was an acute spongiotic dermatitis. The diagnosis was acute allergic contact dermatitis. Slide number 2, the correct diagnosis was subacute allergic contact dermatitis. Slide number 3 was pityriasis rosea, could have been EAC too. Slide number 4 was seborrheic dermatitis. Slide number 5 was stasis dermatitis. Slide number 6 was Incontinentia pigmenti. Okay. Slide number 7 was plaque-like psoriasis. 8 was Guttate psoriasis. 9 was Lichen simplex chronicus. And 10 was Pityriasis rubra pilaris. Okay. Do we have any other questions? Don't see any in the chat. So again, if you have any other, please feel free to contact me. And I hope you have a great evening. Thank you.